as many of you will already know, they run a wonderful educational program for patients so that you are able to make informed decisions and choices and also relevant questions. I'm absolutely delighted to introduce this evening Dr. Abraham Zavala from Clínica Tambre, based in Alicante in Spain. He is a gynecologist with a specialism in fertility and most especially focusing on repeat implantation failures and recurrent pregnancy loss, which is an enormously important topic. This evening, he's going to be speaking for us on AMH levels and their impact upon fertility. And so before I hand over, I just want to say most of you will have seen that we have a lovely chat box for you on the right-hand side. Please do post any questions in there. They will all be anonymous. The session is being recorded, but if we will ask your questions at the end of the session, and we will make sure that we answer as many as we possibly can. If that isn't possible, then the questions will be forwarded on to Dr. Zavala on your behalf, and we will make sure that those questions get answered for you. So without any further delay, I'm going to hand over the presentation to Dr. Zavala. I think we're going to have a very interesting evening.
Thank you, Barbara, and I'm delighted to be here.
I'm just going to load your presentation, so just bear with me.
Yeah, sure.
Let's make sure we have the right one here. There we are. I just want to make sure, can you see that clearly?
Yes, I can.
Perfect. Okay, I'm going to hand over to you and take my video and sound off, and I will keep an eye on the chat box for you and feedback when we get to the end of the presentation. So thank you so much for being with us this evening.
Thank you, Barbara. Okay, so as Barbara mentioned, today we will be speaking about a very common topic in assisted reproduction. Most patients that have gone through any sorts of treatment in fertility would have come across these three letters, the AMH. And we will talk about what this AMH is and what impact it can have on both fertility and fertility treatments. And just to reiterate, my name's Abraham Zavala. I'm a gynecologist and fertility specialist at Tambre Clinic in Spain, in the city of Alicante. Okay, so these are the points that we will be covering today. So we will start out with what the AMH is and what the concept of ovarian reserve is and what it means. And we will give an overview of the definition and the background of both of these terms. Okay, we will talk about different biomarkers that we can use to assess the ovarian reserve and to differentiate between the two concepts of quantity and quality, or quantity versus quality. Okay, then we will move on to what levels of AMH we expect according to a woman's age and the special situations or underlying conditions that may interfere with those expected AMH levels. And finally, we will talk about diminished ovarian reserve, or DOR, and what impact DOR or low AMH levels could have on fertility. Okay, so we will start out with a introduction to what the AMH is. So AMH stands for anti-Müllerian hormone. And I have made a very concise summary of the main points that we should cover about the AMH. Okay, so what is the AMH? The AMH is, first of all, a hormone. Okay, and this hormone is a glycoprotein that is produced by the granulosa cells of early follicles. Okay, so if you see the image on the right, you will see that these are all follicles, okay, at different stages of its development. Now, if we could zoom in on this follicle, we would see that on the outer edge of the follicle, we would find granulosa cells, okay? Now, these granulosa cells are the ones that are going to be producing the AMH hormone, okay? And why is it called AMH? Why is it called anti-Müllerian hormone? That's because initially it was named for a hormone that that aids male development. Okay, female structures come from something called from a structure called the Müllerian duct. So by producing AMH, these Müllerian ducts will stop developing, and the embryo or fetus will start developing into a male phenotype with male internal organs. Okay, so that's where the name comes from. And what does it do? Well, it prevents follicle recruitment from the resting pool of eggs. So what does that mean? Okay, so we know that an ovary holds a large amount of follicles. Okay, the reason why they don't ovulate during any one cycle is because of the AMH. The AMH is keeping those follicles at rest so that they are not recruited along with other follicles. So we can say that the AMH is a type of gatekeeper of follicular development. Okay, and this is why we can use it as a biomarker for the ovarian reserve. Okay, the more follicles your body's trying to keep at rest, the more AMH it needs to produce. And that's why we can measure it to assess the amount of follicles that you may have. Okay, so now we should talk about what the ovarian reserve is. Okay, so the ovarian reserve is a very unique concept to women. Okay, this is something that doesn't happen in men. There's no such thing as a sperm reserve, for example, right? That's because sperm cells are being generated in about a 3-month period, pretty much along a man's lifetime. But follicles aren't. Okay, follicles, women are born with the number of follicles that they will use throughout their lifetime. So if we wanted to define what the ovarian reserve is that remaining supply of follicles or eggs, the name for them is oocytes, okay, that the ovary holds at any given time, okay? This can be a high or a low ovarian reserve depending on different factors, but the main factor that's going to depend on is the age that we're at, okay? So, for example, in this graph, we can see that the highest peak or the highest amount of follicles are actually found before that woman is born, okay? And then it starts coming down, all right? And then after puberty, that's when they start declining each month. Now we see a very important decline between the ages of 35 to 38. And finally, once that amount of eggs or that pool of follicles is depleted, we will no longer have ovulation, and thus we would have arrived at menopause. Okay, so we know that this finite number of eggs is going to decline with age. We're going to start seeing a major decline in the early 30s, but a more rapid decline after the age of 37. And that follicle decline is called atresia. Okay, it's that the follicles are no longer able to produce an egg. All right, so we know what the ovarian reserve is, and we know that we can use the AMH to tell us the amount of follicles that we may have remaining. Okay, so is this the only way that we can measure the ovarian reserve? Well, no. And first of all, we need to make a difference in the way that we measure the ovarian reserve. Okay, and we're going to come up with two parameters. So on one hand, we're going to have the quantity. That means the amount of eggs or follicles that we want to measure. Okay, and on the other hand, we're going to have the quality that those eggs may have. Now, I'm not going to go further into what quality is, but first I want to talk about how we can assess the quantity, because that's something that we can more objectively measure. Okay, so one of the ways that we started measuring the quantity or the amount of eggs that we have was by measuring the hormonal levels at a very specific point in your cycle, anywhere from day 3 to day 5 of your cycle, because that's when the hormones are basically at rest. We haven't started stimulating the follicles, so your estrogen levels, FSH, LH, and progesterone levels are all going to be quite low. Okay, and we use the FSH and LH to measure the amount of hormones that your body needed to produce to get that ovary to generate a growing follicle. Okay. However, there are some disadvantages to using FSH, and one of those disadvantages is that it won't give us a precise number. It's just telling us whether the ovary is struggling or not to develop a follicle, and the changes that happen in the ovary usually take a lot longer for them to reflect on the FSH levels. Okay, so normally we're going to want to have an FSH and an LH below 7, but it can be considered normal whenever it's below 10. Okay, when it's above 10, we would suspect that the ovary is struggling a bit to develop follicles. Okay. Now, another way in which we can assess the ovarian reserve is through an ultrasound scan, specifically through a vaginal scan. Is it possible to do it abdominally? It is, but we won't get the same definition of the ovaries, because we want to look at structures that are very small within the ovaries. Okay. Now, this is what we call the antral follicular count or antral follicle count. And it's basically counting the number of follicles on each ovary to determine whether we have a normal ovarian reserve. Okay, anything above 7 or 10 follicles, by adding the right and the left side, can be considered normal. Okay, now what is an antral follicle? It's usually the follicles that are going to be between 3 to 10 millimeters. And when can we do this? The ideal time for us to do this ultrasound scan would also be during the first few days of your period, so anywhere from day 3 to day 5. However, we really are able to do it at any point in your cycle. One of the disadvantages to doing it at any point in your cycle is that if you have a growing follicle or a follicle that's already ovulated, since this tends to be a larger follicle, it may hide some of the follicles that we would otherwise be able to count. Okay? And then we have one of the most trustworthy parameters, which is the AMH itself. Okay, so if we were to only use one of these tools to assess the ovarian reserve, the AMH would probably be the preferred biomarker for assessing quantity. Okay, but ideally, we would use a combination of these three to get a better picture of the ovarian reserve. Okay. Now, the other parameter of the ovarian reserve that I was talking about is quality. Okay. And when we talk about quality, we really don't mean the size, shape, or symmetry that the eggs may have or that the follicles may have. What we mean by quality is the potential that that egg has to become a genetically healthy embryo. Okay, so that's what we mean by quality. And there's really no way for us to measure quality. In fact, the only correlation that we've been able to find is that the younger the woman is, the better quality the eggs may have. Now, I'm going to leave it at that for now, but once we see that graph, we'll see that there is an exception to this rule, okay? All right, so this is the graph that I was talking about regarding quality. Now, these parameters in terms of the amount of eggs and the quality usually have some sort of correlation. And that's primarily because the younger we are, the better quality we can expect from the eggs. And it's also usually the time at which we have a greater amount of eggs. So that's why there's a strong correlation between age and quality and quantity. Okay. However, that's not always the case. So, for example, a high AMH implies more eggs than we would expect, but it doesn't guarantee that the egg is going to be of good quality. Okay. And the other way around is also true. We may have a very low AMH at a rather young age, and that would mean that even though we have fewer eggs, those fewer eggs may still be of really good quality. Okay. Now, in this graph, we'll see that there's a type of J-shaped phenomenon going on, because this graph is telling us the amount of aneuploid or chromosomally abnormal embryos that we would expect from eggs depending on their age. Okay, and for example, you will see that there's a higher proportion of aneuploid embryos that we could expect at 22 than we could expect at, for example, 28 or 29. Okay, which may seem a sort of juxtaposition, but there is plenty of evidence that seems to show that there is an ideal time in terms of egg quality that rests somewhere between the ages of 25 and 29. So it seems like, for example, being 24 or 25, or at 24 or 25, you would have a greater chance of having healthy embryos than at 18 or 19, okay? Now, going back to one of the points I was making about how there may be some situations in which we have a low AMH at a young age, and thus we may still have good quality, and even though we have fewer eggs. While age is one of the strongest predictors of pregnancy, quantity and quality are not entirely independent, in the sense that a low amount can also be a sign of lower quality. Okay, so they're not always completely independent, but it doesn't mean that by having a low amount, we necessarily also have to have a low quantity, depending on that woman's age. So we know that the pool of eggs or the pool of follicles is going to decline with age. And that's something that's going to happen throughout a woman's lifetime, but it's going to happen more rapidly after the age of 30, okay? And specifically after the age of 35. Now, this doesn't mean that all 35-year-olds or all 38-year-olds are going to have a low AMH. In fact, the AMH results can vary widely, even within the same age group. So that's why it's always important to do an AMH test and know what ovarian reserve you have. And also to combine it with other tools for assessing ovarian reserve, because we know that, for example, the antral follicular count and the AMH levels are correlated most of the time, but up to 20 to 25% of women may have different results in terms of antral follicle count and AMH. So for example, let's say that we have a close to normal antral follicle count on the ultrasound scan, but a rather low AMH, okay? Which one should we go with? Well, we always have to individualize the results and, take the patient's context into account. But in that case, we would usually go with the AMH value, because the AMH is going to tell us which of the follicles that we're seeing may be active. So there are some follicles that may be cysts that we think are follicles, but it doesn't mean that they would produce an egg or that they would hold an egg inside of it. This is just an image to give you some sort of context to what AMH levels we would be expecting according to age. And also, as a consultant at a Spanish clinic that sometimes sees a lot of British patients or patients from all around the world, I want you to know that there are two different ways in which we can measure the AMH. In Spain, we usually measure it in nanograms, compared to the UK, which they usually measure it in p-mole. So they are quite different. But a basic rule of thumb is that 1 nanograms equals 7 p-moles. Okay, and the amount or the value of the AMH can also give us an idea of the amount of eggs that we would expect to collect during an IVF stimulation. Okay, now AMH is not the whole story, in the sense that there are other factors that come into play when considering the amount of eggs that we could potentially retrieve. We also need to know how that ovary would respond, and really the only way that we would know that is by actually performing an ovarian stimulation. But this does give us a general idea of what we could expect. Now, there are special cases in which we need to consider that the values of AMH may be different than we expect. And one of the more important ones is something called premature ovarian insufficiency, or POI. Now, this condition used to be called premature menopause. Okay. Now we know that it acts a bit different than premature menopause. The reason why it was called that is because when a woman didn't have her period in over a year, she'd be diagnosed with menopause. And this could sometimes happen in about 1% of women before the age of 40. Okay, so that's why it was called premature menopause. But now we know that when it happens to women before the age of 40, there are many factors surrounding this condition. And what we've seen is that it doesn't imply a complete shut off of the ovarian function like we would expect from menopause. We know that it could be intermittent, and and it could be a slower decline of that ovarian function. So that's why it's now referred to as POI, or premature ovarian insufficiency. So in this group of women, we would expect very low levels of AMH, okay, compared to what we would normally expect from that age group. Okay, so in these group of women, whether they develop POI at the age of 30, 35, or 40, we would expect lower AMH values than other women within the same age group. Okay. Endometriosis is another condition in which the ovarian reserve may be affected. Now, with endometriosis, we could expect this condition to affect the quality of the ovarian reserve, but also the quantity can also be impacted with endometriosis. But more often than not, the bigger impact on quantity from endometriosis actually comes from the surgical treatment of it. So this is a situation that we always need to take into context to decide whether surgical treatment is warranted or not. Okay, but in this group of women, we often also see a lower ovarian reserve than expected. Okay, and then we have the complete opposite, which is polycystic ovary syndrome, or PCOS. In this condition, we're going to have an excess of small follicles that will be producing more AMH, sometimes 2 or 3 times higher than other women within the same age group. And this is something that we can suspect when we have AMH values over 4. So that would be roughly over 28 in terms of people. So as I was saying, the AMH, or even the ovarian reserve, is not going to give us the full picture as to what we could expect from any given IVF cycle. We also need to take into account how that ovary may respond to the medication. So there is a group called the Poseidon Group that developed guidelines for us to assess that ovarian response. And this is divided into 4 types of patient groups. And basically, we're going to have women either under 35 or above 35 that may have a normal ovarian reserve or a diminished ovarian reserve. And we're going to have patients on any of these groups that at some point may have a poor ovarian response, or a POR. And this poor ovarian response is defined as us getting less eggs than her ovarian reserve, or the amount of eggs that we would expect to get from her ovarian reserve. Okay, so even though AMH can predict how the ovaries can respond to AMH, to the AMH, with that AMH, we can determine the dose and the amount of medication that we're going to use. But ultimately, it's up to the ovary to how it's going to respond to that medication. Okay. Now, it can also help us determine the chances of success from any given treatment, since a low AMH may imply acquiring fewer embryos, and that can reduce the success per IVF attempt. So that could help us also determine the number of IVF cycles that we would expect that we may have to do in order to achieve pregnancy. Okay. And also, AMH can help us personalize treatment depending on how your ovary responds, the amount of eggs that we have, the number of embryos that develop, and this can help us make decisions on whether we should maybe egg bank or embryo bank, or decide whether PGTA may be an option, or whether egg donation would offer us with a better success rate. But something important that we always need to remember is that no value of AMH should determine who does and doesn't get treatment. Now, the summary of this presentation, or the take-home message that I think that we should convey, is that while AMH is a great biomarker for assessing the ovarian reserve, it's really going to be a combination of the different tools that we have, especially AMH, antral follicle count, and age, to give us that full picture of where we're at and what type of treatment and the amount of medication that we should use to expect the best response. Okay, because we're always going to try to get the best results using the least amount of medication. One of the more difficult areas, I think, of fertility treatment is setting expectations. And I think that AMH, or ovarian reserve testing for that matter, also goes a long way into kind of setting our expectations, determining what type of treatment would offer us a better result, and the number of attempts that we may need. And finally, communicating this to our patients is important, because we need to understand that there's no single test that is going to determine whether you can or can't achieve pregnancy. Even very low levels of AMH have to be taken into context and to the specific situation that that patient may be navigating through. So AMH is a powerful tool for assessing ovarian reserve and aiding in IVF planning, but is not a fertility verdict, in the sense that is not going to tell us whether we can or can't achieve pregnancy. Okay, so I hope you've enjoyed this information, and I'd be happy to go over your questions.
Thank you so much. That was very comprehensive and I think really easily understandable. So I thank you. I'm just going to remove the PowerPoint so that we can see you, which is wonderful. We've got some really interesting questions. People are obviously finding that interesting and applying it to their own circumstances. I just had a couple of things which I wanted to ask before if it's okay, before I go to.
Yeah, of course.
I think you said, and I may have heard this incorrectly, that there was in younger women around the age of 22-ish, there was an increase in aneuploid embryos. Was that correct?
Yes, as I said, we've seen that there's a type of J-shaped graph that we see in the chances of achieving healthy or unhealthy embryos according to age. And for some reason, there's a slightly higher chance of achieving aneuploid embryos in women younger than 22 or 23, compared to women anywhere from 25 to 28. Okay, and this is something very interesting that it's not expected, but it's something that we've seen over and over in different types of research.
Absolutely fascinating, and I'm guessing to date there isn't quite an understanding yet of why that might be.
Yeah. There isn't.
That's extraordinary. Thank you. Thanks for clarifying. So the other thing I wanted to say was, when we're talking about there being lower numbers of available eggs for retrieval, is there an argument for retrieving less, and would that impact on quality? So I guess what I'm saying is, if there were fewer retrieved, would that improve the quality of the embryos?
Yeah, so that's a very good observation and a very interesting chain of thought. And that's something that was addressed at some point. And that's when we started doing something we called mild stimulation protocols, in which we try to give very low doses of medication in the hopes of achieving perhaps a lower amount of eggs, but maybe a better quality. But at least where the current research is at, we've seen that higher doses of medication don't really have an impact on egg quality. What does have an impact on fertility treatments is the more eggs, the better chances that we have to get to that healthy embryo to achieve in order to achieve pregnancy. So that's why I mentioned at some point that we really want to get the most amount of eggs possible. Yes, with the least amount of medication, but we in no way consider giving any less medication than the absolute maximum number of eggs that we could potentially retrieve.
Okay, so that's really fascinating. So I guess what you're saying is, statistically, the more embryos there are, the more likely you are to have euploid embryos, and therefore increase positive
Yeah,
outcomes.
it's a and I don't mean to demean the treatments at all, but numbers and statistics do have a huge impact on outcomes. Um, so yes, it really does come to the more eggs we have, the higher chance we have of getting that healthy egg to generate a healthy embryo. Because in no point um, within the AMH and within a certain age, it doesn't mean that that patient wouldn't be able to achieve pregnancy or have a healthy egg. It just means that there's less likely to. They're less likely to. Okay, so to kind of think about it from another point of view, if let's say a 43-year-old patient came to me as a gynecologist and said, Abraham, right now is really not a good time for me to achieve pregnancy. I really don't want to get pregnant right now. I would need to give that person birth control, because otherwise there is a chance that she may achieve pregnancy. Okay, so that's kind of the shoe on the other foot, but yeah.
Yeah, that's such a good answer. Thank you so much. It really clarifies things. My last little question before I go over to the wonderful questions we've got from people who are listening, is I wondered if there was a correlation between PCOS and egg quality. The very high numbers of follicles that are present, and whether that influenced egg quality.
Yeah, so with PCOS, we know that there's an abnormal stimulation to those follicles. Okay, the FSH and LH levels tend to be they tend to have a different configuration than normal. There can be certain amount of insulin resistance, and there could be an increase in the amount of male type hormones, which we call androgens. So this could affect the quality of the eggs. And PCOS as a whole also affects ovulation. So those are the two ways in which PCOS can decrease the chances of us achieving pregnancy, even though we have a very high AMH.
Yeah, and my guess is, I mean, actually what you've been saying all the way through is that it's the individualized approach for each patient which is so important. And I'm guessing never more so than in women with PCOS, you need to understand their individual circumstances.
Yeah, exactly. I feel like with everything in biology, there's a bit of a sweet spot that we want to fall into, and AMH is no exception.
Yeah, fascinating. So it's so important. Thank you so much for answering my questions first. So what I'm going to do is I'm going to go through. We've got quite a lot of questions that have come in, and I'm just going to go through them in the order that they have arrived. And I'm just going to use first names so we don't identify anyone. So we have Gabriella, who has an AMH of 0.5. She's 43. Can she conceive naturally or with IVF? She also says that FSH is 11, and she's had 2 aneuploid embryos, I think she's saying last year.
Yeah. Okay, so to break down your question a bit, if the question is, can I conceive naturally? And I had to give a yes or no answer, the answer would be yes, you can. But the chances of achieving pregnancy are lower, okay? Part of the reason for that is because at 43, a higher proportion of eggs that you produce are not going to yield a chromosomally normal embryo. Some of those eggs, or most of those eggs, are going to yield an aneuploid embryo. Okay, by trying to conceive naturally, you would be producing about 1 egg per cycle. So your chances of having a healthy embryo would depend on that 1 egg, right? Now, with an AMH of 0.5, through IVF, we would expect to collect a greater number of eggs than just 1 per cycle, maybe anywhere from 3 to 6 eggs. That's what we could expect from that AMH. By getting more eggs, we could increase our odds of getting to a healthy or getting to a euploid embryo. Now, even though we have a higher proportion of eggs, we still have those same percentages in the sense that most of those eggs may be aneuploid. So that's probably the reasons why the 2 embryos that you've had have been aneuploid. In terms of the FSH, it's a bit increased. Okay, so we have to remember that the way that your hormonal axis works is your brain will send off FSH to stimulate your ovary to make that follicle grow. As that follicle is growing, it's going to start producing estrogen so that your lining thickens. Okay, now the reason why FSH starts going up with age is because your body needs more stimulus for those follicles to develop. So when FSH of 11 is telling us that your ovary might be starting to struggle with the follicular development.
That is a really comprehensive answer, Gabriella. I hope that's really helpful to you. Thank you so much. The next one is from Katie, and she says, is it possible to perform unnatural FET with the presence of an ovarian cyst between 2 and 4 centimeters and ovulation confirmed in that cycle? Should the cycle be cancelled in this case?
Okay, so it sounds like, so by saying a natural frozen embryo transfer, I assume that the embryo is frozen right now and you're doing a natural preparation of your lining. Now, during a natural preparation of your lining, we would expect a follicle to develop, and we would time the ovulation, okay? The reason why we do this is because the embryo that we're trying to transfer is, I assume in your case, is a blastocyst or a day 5 embryo. But even if it was a day 3 embryo, we would use the same logic, okay? So a day 5 embryo, we're going to want to transfer it into an endometrium or into a lining that has been exposed to progesterone for 5 days, okay? That's why we need to time the ovulation just right. Because if we induce that ovulation, then we know when your lining has started to have exposure to progesterone. If we didn't time that ovulation, then we don't know how long your lining has been exposed to progesterone, and that may be out of sync with the embryo that we're trying to transfer. So we would expect for you to ovulate in a natural endometrial preparation. But if we didn't time this ovulation, then perhaps it wouldn't be the right time to transfer that embryo.
Wonderful. Thank you. Thank you very much. We've got quite a few questions here. They seem to be fairly straightforward, so I'm going to keep going with them as long as we can, if that's okay. So we have Yana, who says, can AMH increase? She found a substantial increase since her last test from last year, and I do not know if I should be happy or repeat the test.
So we used to think that AMH was this constant value, right, that didn't change, right? Now we know that there may be factors that affect the AMH value. Using contraceptives for some time, there's little variation, but also the time in the cycle in which you perform the AMH test can give us different values. As I said, the units in which we measure AMH are also different depending on the country in which you've measured it, and even the lab, I guess. And there's also some variation by having that test performed at different labs. Okay, so if we were to answer this question, AMH doesn't tend to increase, as we've seen with the graphs along our lifespan. It actually tends to decrease or follow a downward slope. Okay, so if the variation is too high, I would get another test to kind of put things into context.
Wonderful. That's great. That's a really great answer. I hope that's useful, Yana. This one I may put on the screen because it's got a fair bit of data in it. So this is from Ellen. I will just read it out, but I am going to display it as well. Oh, shoot, here we go. So she's 38. AMH of 7 p-moles, antral follicle count of 13, 6 follicles matured. It looks like medication was 300 IUs of pergoveris and cetrotide at 0.25 milligrams. Egg retrieval, 3 empty and 3 eggs retrieved, 1 immature and 2 mature, I think that is. 2 triggers, and the question is, what are the causes of empty follicles? Is it the low AMH, or did she ovulate early? Thank you.
Okay, so this is one of the perfect examples of what we were talking about before. Okay, so here we have an AMH of 7 p-mole, which roughly translates to about 1 nanogram over milliliter. Okay, so with one nanogram or with 7 p-mole at the age of 38, we could expect anywhere from 6 to 8 eggs. Okay, now we have a much higher antral follicle count of 13, but ultimately we do see 6 follicles that kind of continue that growth. Okay, so the amount of follicles is more in line with the AMH value that we were seeing. Now, on the egg retrieval, 3 of those follicles were empty, and 3 of the eggs that we got were mature. But from those collected, I'm not sure if they were all immature or there was 1 that was mature or 2 that were mature, because I think that you had a bit of a typo when typing this. But yeah, I guess we would need to know that, because 2 mature eggs out of 3 would be an expected result. 1 out of 3 may be a bit lower. And you had two different types of trigger. So in terms of what may cause the empty follicles, I guess we would need to know the size that these follicles reached. We know that ideally we want the follicles to be anywhere from 17 to about 20 millimeters. Those have the higher chances of having a mature egg inside of them. There is a possibility of a premature ovulation, and this is something that we can also find out by measuring your progesterone before the trigger shot.
Perfect. That's a really comprehensive answer. I really hope that has helped, Ellen. Whoops, sorry, everybody. I'm just... There we go. Sorry, everyone. I'm just going to go back. Just managed to get the presentation up rather than... There we go. So we have two questions from Yasmina. I'm guessing one leads into the other. So she's asking whether you would recommend platelet-rich plasma treatment for low AMH, low ovarian reserve, and what protocol you would then recommend for women who are poor responders to antagonist stimulation or have a low ovarian reserve. So it's kind of several pieces, several questions in that.
Okay. So regarding the first question about recommending PRP, it's really going to depend on the context of the situation, right? So PRP, for those who don't know, is platelet-rich plasma. Okay, it's when we draw blood and isolate the platelet portions of the blood. Now you may be wondering, what kind of benefit we would have by concentrating platelets, and the answer is no, really. But when these platelets break, they release growth factors, and that can help in certain areas of fertility treatments. There are 2 main uses for PRP. We can use it in cases in which endometriomes or linings have a hard time growing, and it's also been there's quite a bit of research on using PRP into the ovary to see if we can improve ovarian reserve parameters. Okay, and it's an experimental technique. Okay, what we've seen is that by infusing PRP into the ovaries, we can see an increase in the ovarian reserve parameters. So we may have a decrease in the amount of FSH. We may see an increase in AMH, but unfortunately, an improvement that PRP has failed to show is an increase in live birth rates. Okay, so in the context of you being 31, I think that it's something definitely worth discussing, and probably considering it as an option. But in other situations, I don't think that it may be the most recommendable technique to use.
Thank you for that. Actually, I think you will find, if you go and look at the bank of webinars on the IVF Answers website. I know that I hosted a webinar on PRP, which had lots more information. If you want to go and gain some more information on that, you might find that useful. But thank you, that's really helpful. Are you happy for me to continue for a little bit longer?
Yeah, go ahead.
Yeah, is that okay? So Katie is asking, would a low AMH level impact a natural frozen embryo transfer with donor eggs, considering ovulation occurred in that cycle?
I feel like we've already answered one of Katie's questions. Let me just scroll up to see if this has anything to do with the previous one. Okay, so this was the frozen embryo transfer from a natural cycle. And now she's asking, would a low AMH level impact a natural FET, considering ovulation occurred in that cycle? Okay, so she's bringing up an important concept, okay, and that is that AMH or low levels of AMH don't necessarily mean that your natural cycles will be impacted. Okay, in order for you to have a period, you must have ovulation, at least for a natural period. Okay, whether you get a period with hormones or with birth control, that's different. That's a period that doesn't come from ovulation. But natural periods or natural cycles are a consequence of ovulation. Okay, so a low level of AMH, if you're having regular periods, should not impact a natural endometrial preparation for a frozen embryo transfer. Okay.
Wonderful. That's great. That's very clear. I hope that helps, Katie. And then we have two from Karen. The first one is, can you offer human growth hormone to help with getting more follicles? And then that goes into, can you do anything to get the follicles to grow together rather than in separate groups of different sizes? And do you offer estradiol priming for this? So it's like 3 different questions there.
Yeah, 3 different questions, but all very interesting. So regarding growth hormone or Sizen, it's one of those options or add-ons that we can use during stimulation protocols, but it doesn't have enough evidence to show that there's an actual improvement in pregnancy or in live birth rates. So that's something that you need to discuss with your doctor to see if that would offer any benefit to your particular situation. Now, in terms of estrogen priming or estradiol priming, the main reason for using that priming or taking estrogens in the cycle before the stimulation is usually to increase the amount of receptors that your ovary will have during the stimulation protocol. So that's the purpose of using estrogen priming. It doesn't necessarily have an impact on follicles growing together. Now, when follicles don't grow at the same time, we call this asynchrony. And this is something very frustrating that can happen, because we do want the most amount of follicles to grow at the same time so that they reach mature, so that you get the most amount of mature eggs in the egg collection. Now, there are different tools that we can use when we have an asynchronous stimulation cycle. One of the ways that we can sort of prevent this is by using actually birth control in the previous cycle, and other strategies are to maybe use either orgalutran or cetrotide during the first few days of the stimulation cycle.
Perfect. That's really helpful. I hope that helps, Karen, and answers your questions. We've still got quite a few questions that are in the chat box. So I'm going to suggest that what we do, perhaps if it's okay with you, is do one more, and then I'll ask Caroline if she can forward the others on to you. Would that be okay? Otherwise,
Yeah.
yeah, is that all right? So Yasmina has asked whether you recommend testosterone gel to improve egg quality.
So it's not going to improve egg quality, or that's not the purpose of using androgen priming. But there was a huge clinical trial on this that presented their results. I want to say last year, maybe the year before. But what it showed is that it may increase the amount of eggs that we do collect by one additional egg. And as I said, we really want the most amount of eggs to try and find those good quality eggs. So it doesn't directly improve quality, but it may improve the quantity that'll help you get to the quality. Does that make sense?
Yeah, that makes absolute sense. So then what you may find is that you've got access to more euploid embryos rather than
to more chances of getting to that one.
Wonderful. Okay. I think what we'll do is, because there are quite a few questions left, which, and some of them seem slightly more complicated and need quite a developed answer. So I'm going to suggest that what we do is we ask lovely Caroline to pass those on to you, Abraham. And I just want to say thank you to everybody who's joined us today. Thank you for your very interesting questions. They've been insightful and really very interesting and thought-provoking. And by no means least, thank you for being with us, Abraham, on behalf of My IVF Answers and the European Fertility Society. It's been a really interesting evening, and I know very informative for all the patients that will get to listen to this afterwards. So a huge thank you for being with us. It's been such a pleasure.
Thank you. It's been my absolute pleasure.
I'm sure they will ask you to come and speak for us again on lots of other topics. So hopefully we'll meet again, and I may even get over to Alicante at some point. That would be lovely.
That'd be lovely, yes.
Okay, thanks very much everyone for being with us, and have a good evening, and take care of yourselves.
Good evening, everyone. Bye.